Good evening to everyone. We know that a famous saying goes, nothing is permanent but change. But interestingly, while the outpatient management of diabetes has changed drastically, the inpatient management of diabetes has remained the same for a pretty long time. However, recently the winds of change have started blowing, and in-hospital hyperglycemia management is also changing, particularly with regard to the control of basal glucose with ultra-long-acting insulins. And that is what we'll focus on over the next 15 minutes or so. We'll look at certain key pharmacologic concepts. We'll look at some publications with regard to ultra-long-acting insulins. And of course, we'll top it up in the end by looking at our very own Indian publication. Now, when we think of long-acting insulins, we think of insulin degludec, U100 glargine, and U300 glargine. What is interesting is that degludec, in spite of having the longest duration of action, has the quickest onset of action. So it has to do with its method of protraction. We know that degludec is present as a multi-hexamer from where it gets transformed to monomers and gets absorbed. Glargine, on the other hand, is precipitated at a neutral pH, and from these crystals, it gradually gets absorbed. So because of its unique method of protraction, the onset of degludec is quickest amongst the long-acting insulins, in spite of it being the longest acting one. And this gives it the advantage that the blood glucose starts coming down quickly. And interestingly, if you look at its pharmacokinetics, you can titrate it pretty quickly. The time to steady state of degludec is as low or possibly slightly lower than that of U100 or U300 glargine. So quick onset of action, early time to steady state. Now, does it translate into better in-hospital glycemic management? That is what we look at the rest of the presentation. Now, when we talk of in-hospital use of the longer-acting insulins, insulin degludec in particular, I need to say that there are several studies. I'll be focusing on the three most prominent ones amongst them, a study from the United States of America and two studies from Italy. The first study from the United States of America is, I would say, sort of a proof of concept study, where degludec was used in patients admitted to both the medical unit as well as the surgical unit with a daily titration regime. So daily titration in both the units resulted in better blood glucose lowering without any increase in the risk of severe hypoglycemia. Now again, this study included patients about 2/3 of whom were already on insulin before the time of admission. So it was the patients had relatively longer duration of diabetes, but with daily titration of degludec, they attained their blood glucose goals without an undue increase in the risk of hypoglycemia. So this study gives us the confidence that yes, degludec can be used in an inpatient setting with a daily titration algorithm. The next study that we would like to discuss is an Italian study, and it's a famous study which goes by the name of IDIOS study. In this study, it was degludec in one arm of patients, and in the other arm of patients, U100 glargine was given. And 4-point capillary blood glucose monitoring was done, fasting, pre-lunch, pre-dinner, as well as bedtime. What was found interestingly was that at every time point of these 4-point capillary blood glucose monitoring, the patients who were on insulin degludec had significant glucose lowering from baseline. However, the patients who were given U100 glargine had significant glucose lowering only in the pre-lunch period, not in the fasting period or in the pre-dinner period or at bedtime. What was even more interesting was that in spite of the patients on degludec attaining better blood glucose control at all the 4 time points, they had a lower incidence of hypoglycemia, a lower incidence of diurnal hypoglycemia compared to patients on glargine, and no episode of nocturnal hypoglycemia, whereas those on glargine had 2 episodes of nocturnal hypoglycemia. Now, this study initially looked at degludec versus U100 glargine, and later, in a part of those on U100 glargine, the patients were shifted to insulin degludec to see if the outcomes became any better. What happened was that when patients were shifted from insulin glargine to insulin degludec, their glucose control improved and their rates of hypoglycemia went down. Now, this was something interesting because we know that as we go closer to our glucose control targets, as we lower blood glucose level, the risk of hypoglycemia usually goes up. But in this study, the patients who received degludec initially had better glucose control with lesser hypoglycemia rates. Those on U100 glargine, when shifted to degludec, had better glucose control subsequently with a lowering of hypoglycemia. And this unique property of degludec makes it something interesting to use not only in the outpatient setting, but also in the inpatient setting, where you can up-titrate more vigorously with greater confidence without an undue increase in the risk of hypoglycemia. Now, when we talk of glucose control, we also talk nowadays of a decrease in glycemic variability. You need to control the glucose well, and you need to reduce the glycemic variability to improve outcomes over a longer period of time. Now, this is again a study from Italy, the so-called study from Simeoni N et al., which included patients who had significant comorbidities. This study included about 52 patients, 75% of whom had 3 or more comorbidities. So they were significantly ill patients, and it was done in an inpatient setting. On admission, their fasting plasma glucose was about 237 milligrams per deciliter. However, there was a lot of glycemic variability, with the standard deviation being about 125 milligrams per deciliter above and below the mean fasting plasma glucose level. All of these patients were put on insulin degludec, and at the time of discharge, the fasting came down to 150 milligrams per deciliter, around about 150 milligrams per deciliter. And the standard deviation of fasting variability came down from 125 milligrams per deciliter to only about 38 milligrams per deciliter. So this study nicely demonstrates that with the use of degludec, not only does the fasting come down significantly, but the variability of fasting comes down as well. And I think this predictability of degludec is something which gives it an advantage, not only in the outpatient setting, but also in the inpatient setting. You know that when you give a certain dose of degludec, you will have a certain degree of reduction of blood glucose. It doesn't oscillate between a wide range with a certain dose. And we have a number of pharmacologic studies which actually shows how degludec is different from the other long-acting insulins. As I discussed earlier, the mechanism of protraction of action of degludec is entirely different from that of glargine. And it's possibly this mechanism of protraction of action of degludec which gives it a smooth 24-hour profile. For example, if you compare the profile of degludec on the left to the profile of glargine with a simple example, it will make things clear. Suppose you give 24 units of degludec to a patient and follow up that patient every 6 hours over 24 hours. It will be seen that roughly degludec will act at 1 unit per hour. So 24 unit will be more or less uniformly acting over 24 hours. On the other hand, if you give insulin glargine and follow up that patient at 6-hourly interval, you'll find that over the first 12 hours, about 60% of glargine acts. So roughly about 14 units acts over the first 12 hours. Over the last 12 hours, only 10 units of glargine acts. And this results in increased risk of hypoglycemia in the first 12 hours after giving glargine, and a loss of glycemic effect, glycemic lowering effect towards the end of dose. When you compare degludec with U300 glargine, the results are almost similar, with the only difference being that in U300 glargine, the variability is somewhat lower than U100 glargine. It has a U-shaped curve, but even then, about 55% of its action comes in the first 12 hours. About 45% of the action of U300 glargine comes in the next 12 hours. So within a given day, the fluctuation in the action of U100 glargine and U300 glargine is somewhat more compared to the use of degludec. And it's not only within day variability, but intraday variability. From one day to other, that degludec has different pharmacologic properties from U100 or U300 glargine. The dark blue buildings in these graphs are the action profile of degludec, whereas the gray ones on the left is the action profile of U100 glargine. The gray ones on the right is the action profile of U300 glargine. And as you can appreciate, the gray bars are much more heterogeneous. They are all over the place of different heights compared to the dark blue bars, implying that it's not only within a day, but even from one day to other, that the action profile of U100 and 300 glargine varies. And this lesser predictability of glargine is somewhat of a disadvantage compared to the better predictability of degludec. Now, again, I believe that some of you must have seen presentations with U300 glargine. There are actually some studies which shows that its pharmacologic property is as good as degludec, or it might even be better than degludec. And I believe that if you look at it neutrally, it often depends on who is sponsoring the study. But one action profile of degludec, which is a distinct advantage compared to any form of glargine, is its flexibility. U300 glargine has a flexibility of only plus minus 3 hours. U100 glargine has a flexibility of plus minus 1 hour, whereas degludec has a flexibility of as low as 8 hours, as high as 40 hours, which means that if you give a dose of degludec in the morning today, you can give the next dose at dinner tomorrow and the third dose in the morning the day after without it losing its efficacy, without it losing its flat glycemic action, and without it causing undue hypoglycemia. We know that in an in-hospital setting, a patient might not stay in the ward all across 24 hours. The patient might go for a therapeutic procedure. The patient might go for a diagnostic procedure. And this flexibility profile of degludec gives it a distinct advantage, not only in the outpatient setting, but also in the inpatient setting, where it can be given any time during 24 hours without it losing its efficacy. And of course, degludec, like most other insulins, can be used in patients with renal and hepatic impairment, in the elderly. And of course, it can be used right up to children of 1 year of age. Its label allows it to be used right up to 1 year of age. Now, the last few slides, I'll be looking at an Indian study. This study is interesting not only because it is Indian, but also because it's one of the few studies, or possibly the only study till date, which compared in-hospital use of degludec with U300 glargine, the modern glargine with degludec. And it did so in patients, all of whom had undergone CABG. We know that post-CABG, you need strict glucose control. And in this study, all the patients underwent continuous glucose monitoring. So this was an Indian study comparing degludec with U300 glargine in a post-CABG setting in patients, all of whom underwent a continuous glucose monitoring over a period of 14 days to give you exact idea as to what was the efficacy head-to-head of these two insulins and what was the safety profile of these two insulins. It was a treat-to-target trial where the fasting was maintained less than 140 and the pre-meal was maintained less than 180. So over a period of 12 days, it was seen that the average glucose lowering, the mean glucose lowering, was similar between degludec and U300 glargine. However, if you look at different time points, the pre-breakfast glucose lowering was significantly better with degludec compared to U300 glargine. And the number of patients who attained a glucose level of between 100 to 140 was significantly better with degludec compared to U300 glargine. So this study actually tells us that when you use degludec in the inpatient setting, you can attain better fasting glucose levels compared to U300 glargine in a post-CABG setting. And if you go for more intensive glucose control, 100 to 140 milligrams per deciliter, you can attain it safely, much more commonly with degludec compared to U300 glargine. And if you look at the recent guidelines, in certain settings, particularly post-CABG settings, lower inpatient glucose targets might give you long-term benefits. So to sum up, we have looked at some recent studies which shows that unlike popular belief, contrary to popular belief, degludec can be titrated in every 1 to 2 days. Degludec can be used in an inpatient setting, and when you use degludec in an inpatient setting, you get better glucose control at different time points compared to U100 glargine. You have a lower risk of hypoglycemia compared to U100 glargine. You have more flexibility compared to both U100 and U300 glargine. And importantly, in a post-CABG setting or in settings where you want to attain more intensive glucose control, it helps you attain more intensive glucose control safely compared to U300 glargine. So there's a saying which goes that when the winds of change are blowing, some build walls, other build windmills. I think with the winds of change that is blowing with regard to the use of basal insulin in hospital setting, the onus is on us to take the research from the bench to the bedside to give our patients the benefit of better glucose control. Thank you for your hearing.